and welcome back. So let's revise orthopedic surgery. What is AO classification? It is internationally agreed classification of fracture using alphanumeric code. The first number is the name of the bone. For example, if it is 132, so this first number 132, this first number is the name of the bone. The next letter is ABC, and it is for A it is wedge, for B it is complex, and for C it is proximal and distal segments. A wedge, B complex, C proximal and distant segments. Okay, now the second number is the position of the bone. For example, if 1 is proximal, then 2 is diaphysis and 3 is distal. A is extra-articular, B is partial articular, and C is complete articular. So this is example, that is 1, 2, 1, 3, 2. So 1 is the bone, the name of the bone. So for 1 we are having the bone humerus. If it was, let's suppose 2, that is 2, 3, 2. Then this 2 was femur. Okay, now the second number is 3. So 3 tell us the position of the bone. For example, if it is proximal, then it would be 1. If it is 2, then it is diaphysis. If it is 3, then it is distal. So this is 3. It means that this is the distal part of the femur. Then the next number show us that it is extra articular or partial articular or complete articular. So if it is 2, then it is partial articular. If it is 3, then it is complete articular. If it is 1, then it is extra articular. So we should remember this, that the first digit tell us the name of the bone. The second digit is the letter which tell us the area of the bone. For example, it is wedge or complex, or a type of the bone. For example, it is wedge or complex or proximal and distant segments. And the third digit tell us the position. For example, it is proximal or diaphysis or distal. Now coming towards the first most common topic of the orthopedic surgery, that is dislocation of the shoulder joint. So we are having the scenario that there is a 25-year-old male who has fallen over right shoulder in cricket. Okay, there is a male who has fallen over right shoulder. Now the examination shows obviously deformity of the shoulder. Okay, he has fallen over the right shoulder, so there is a deformity of the shoulder. Arm in abduction and external rotation, and the pulses are normal. So what is the diagnosis, the management, and the complications? For example, if there is a player and who fall over the right shoulder and there is deformity of shoulder, so what is the diagnosis? So obviously it is the dislocation of the shoulder joint because he has fallen over the shoulder. Now what is the management for the shoulder joint dislocation? Okay, remember this thing, that it is easy to diagnose the scenario of the orthopedic surgery. The main thing is that how you will manage the case. Okay, so the head of humerus is driven forward and lies in front of the glenoid. This is the anatomical terms. You should know this, that the head of the humerus is driven forward and it lies in the front of the glenoid. Now the treatment options for the dislocation of shoulder joint are that dislocation should reduce as early as possible, and the methods to reduce are Coker's method, Hippocratic method, and hanging arm or gravitational method. Okay, what has happened that a male has fallen over right shoulder. Now as soon as possible the management should be provided. Now we are having 3 methods for management: Coker's method, Hippocratic method, and hanging arm or gravitational method. What methods? Coker's method, Hippocratic method, and hanging arm or gravitational method. 3 methods: Coker's method, Hippocratic method, and hanging arm or gravitational method. Okay, now let's discuss each one by one. Coker's method. You should remember the Coker's method with TEAR, T-E-A-R. These are the 4 steps. For T is traction, for E is external rotation, for A is abduction, and for R is rotation. Okay, so traction. Traction is applied to arm while flexing the elbow at 90 degrees. First of all, in the Coker's method, what will you do? You will do the traction of the elbow at 90 degrees. Then you will do the external rotation. First of all, traction, then external rotation. Then you will adduction for flexed elbow across the chest. Adduct the flexed elbow across the chest. Okay, now you are fixing the shoulder dislocation. So first of all, what will you do? You will do the traction, then you will do the extension, external rotation, and then you will do the adduction. And at the end you will do the rotation, that is rotate arm back internally until shoulder is reduced with definite clamp. So this is the method for the shoulder dislocation, that is Coker's method. This is one of the major method for the dislocation. What you have done, you have applied the Coker's method to the dislocated joint. First of all, you have done the traction, then the external rotation, then the abduction, and then you have done the rotation. So these are the main steps for the management of the dislocated shoulder. Traction is applied to arm while flexing the elbow in 90. External rotation, then adduction, that is adduct flexed elbow across the chest, and then rotation, rotate arm back internally until shoulder is reduced with definite clink. Okay, now Hippocratic method. Patient lies on bed. Traction is applied to the arm with extended elbow, and traditionally surgeon's heel is applied against side of the patient's chest to promote counter traction. Okay, this is one of the easy method. What is done, that the patient is lied on the bed, then the elbow is tracted in extended position, and then the traditionally surgeon's heel is applied. Surgeon's heel is a type of bandage which is applied to the shoulder, and it is to the side of the chest, which promotes the counter traction. So this was Hippocratic method. Now the third one is hanging arm or gravitational method. The laying patient prone with sandbag under clavicle and hanging arm over edge of the bed holding weight. What happens? Laying patient prone with sandbag under clavicle. Sandbag is placed under clavicle and hanging arm over the edge of bed holding weight. So this help with the shoulder dislocation. What is done in the hanging or gravitational method? Patient is laid on the bed and the sandbag is placed at the clavicle, and a weight is given to the patient with hanging arm over the edge of bed. Now the complications are axillary nerve palsy. What can happen in the shoulder dislocation if it is severe? Axillary nerve palsy and recurrent dislocation. These are the complications of the shoulder dislocation. Okay, so this was the one of the main point. We have the scenario that there is a patient who falls over the shoulder joint. Now we'll discuss the management. So we are having the Cocker's method, the Hippocratic method, and the hanging or gravitational method. In Cocker's method, we have there the distraction, extension, external rotation, abduction, and rotation. And in the Hippocratic method, a patient is laid on the bed and traction is applied to the arm with extended elbow, and traditionally surgeon's heel is applied against the side of patient chest to promote the counter traction. Then we are having the hanging arm or gravitational method, in which the laying patient prone with sandbag under clavicle and hanging arm or edge of the bed holding weight, and the complication is axillary nerve palsy and recurrent dislocation. Now the fracture of the right humerus shaft. We are having the classification of fractures as direct, indirect, complete, incomplete, closed, open, and according to the types, we are having transverse fracture, green stick fracture, compression fracture, spinal fracture, butterfly fracture, pathological fracture, and communicative fracture. Now this classification is very, very, very important. If any question comes from the orthopedic portion in the paper, in the first part of the question which they ask is that classify the fractures of the human body or whatever, it is asked that mention the classification of fracture. So this is the major classification, that is the direct and indirect, then the complete and incomplete, then the closed and open, and then according to the types we are having transverse fracture, green stick fracture, compression fracture, spinal fracture, butterfly fracture, pathological fracture, and communicative fracture. Okay, what are the main types? Fracture of right humerus shaft, we are having direct and indirect fracture. Then we are having complete and incomplete fracture. Then we are having closed and open fracture. Then we are having the fracture according to the types: direct, indirect, complete, incomplete, closed, open. Now according to the types, we are having transverse fracture, green stick fracture, compression fracture, spinal fracture, butterfly fracture, pathological fracture, and communicative fracture. Now for this we should make the mnemonic: transverse, green stick, compression, spinal, butterfly, pathological, and communicated. Okay, GCS, BP, and TC or CT. Okay, we got it. So we should remember this from GCS. GCS is usually Glasgow Coma Scale, and BP is blood pressure, and CT is CT scan. So for GR we are having green stick fracture. For C we are having compression fracture, green stick, compression fracture. Then we are having spinal fracture, green stick, compression, and spinal fracture. Then we are having butterfly fracture, And then we are having pathological fracture, butterfly fracture, pathological fracture. Then we are having communicated fracture, and then we are having transverse fracture, communicated fracture and transverse fracture. Okay, so G for GCS, green stick fracture. For C, compression fracture. For S, spinal fracture. For B, butterfly fracture. For B, pathological fracture. For C, communicated fracture. For T, transverse fracture. Okay, communicated fracture and transverse fracture. Okay, so this will help us to memorize it. For G, green stick fracture. For C, compression fracture. For S, spinal fracture. For B, butterfly fracture. For P, pathological fracture. For C, communicated fracture. For T, transverse fracture. So these are the major classes. Okay, so if the question come in the exam that classify the fracture, so we are having the direct and indirect fracture, the closed and open fracture, and then the complete and incomplete fracture, and then the fracture according to the type. So we should remember it from GCS, BP and CT. So for G is green stick, for C is compression fracture, for S is spinal fracture, then for C is okay, for B is butterfly fracture, for B is pathological fracture, and for C is communicated fracture, and for D is transverse fracture. Okay, so we have classified the fractures, the types. Then what are the treatment options for fractures? We are having conservative treatment, that is use slab with collar and cuff and hanging cast. And then we are having the surgical treatment. Okay, so use slab with collar and cuff. Okay, let's search the use slab and collar fracture. So we are having the conservative treatment, that is use slab with collar and cuff. Arm is bandaged to a slab. Okay, arm is bandaged to a slab of plaster running from the top of acromion down to the lateral side of arm under elbow and up the medial side of arm for 5 cm. Rest the arm in a collar and cuff and give analgesics and maintain immobilization for 3 weeks. This is the general treatment for the fractures. 102. Okay, so what you have to do, we will use the use slab with collar and cuff. That is, arm is bandaged to a slab and a slab of plaster running from the top acromion due to lateral side of arm under elbow and abdominal side of arm for 5 cm. And then rest the arm in a collar and cuff and give analgesics and maintain immobilization for 3 weeks. So this is the basic treatment, that if you have to do the rest and you don't have to immobilize the fracture area. And a use slab with collar and cuff. It is having a collar and a cuff with which the arm is bandaged to a slab of plaster running from the top of acromion down to the lateral side of the arm under elbow and up the middle side of arm for 5 cm. And the arm is rested in a collar cuff and analgesics are given. The hanging cast consists of plaster of Paris cast extended from the axilla to the wrist. This is another type. And what is done? Consists of plaster of Paris cast extended from the axilla to the wrist. And the surgical treatment is indication when a satisfactory result is not achieved with above methods, that is hanging cast and use slab with collar and cuffs, and open fracture, associated vascular injury and multiple injuries, and non-union. If these conditions occur, then we will move toward the surgical treatments. What are the surgical treatment? The indications are when satisfactory results are not achieved with above methods, and when open fracture is associated with vascular injury and multiple injuries, and non-union occur. The procedure is that open reduction and internal fixation using a plate is done, and external fixation occasionally for associated severe soft tissue injuries, and non-union requires internal fixation and bone grafting. This is the procedure. Open reduction and internal fixation is done using a plate, and external fixation is occasionally for associated severe soft tissue injuries, and non-union requires internal fixation and bone grafting. This is the method for the classification of fracture. Conservative treatment, that is use slab with collar and cuff, and then hanging cast, and then surgical treatment. The indications are these we have discussed. So this was about the general treatment of the fracture. We have discussed the classification, then we have discussed the treatment which are use slab with collar and cuff, and then the hanging cast method, and then the surgical methods. And this is the procedure that open the reduction and internal fixation using plate, and in external fixation occasionally for associated severe soft tissue injuries, and non-uniform requires internal fixation and bone grafting. Okay, now coming towards the next very important topic, that is supracondylar fracture of humerus in children. So we are having a scenario that there is a 12-year boy trauma, fall on outstretched hands, unable to move his right elbow, painful and swelling, abnormal in appearance, pain on slightest movement, and right forearm and hand is cold as compared to left. And right radial pulse is not palpable. So what is the diagnosis? Confirm the diagnosis, the management of the skeletal injury, and the management of ischemia in this patient. Okay, so what is this? This is the supracondylar fracture of the humerus. As there is a 12-year-old boy trauma who fall on outstretched hands, and he is unable to move his right elbow, which is painful and swelling and abnormal in appearance, and pain on the slightest movement. The right forearm and hand is cold as compared to left, and right radial pulse is not palpable. So all the clues are about the fracture of humerus. Now which place of the humerus? So it is a supracondylar fracture of humerus. So many of questions are asked here, that what is the diagnosis, how you will confirm the diagnosis, what is the management, and what is the management of skeletal injuries, and what is the management of ischemia. As here is mentioned that there is no pulse, radial pulse in the right palpable, and the right forearm and hand is cold as compared to left. So the investigations of the fractures is always confirmed through X-ray. The most important investigation that is done in orthopedics is X-ray, simple X-ray. The diagnosis is supracondylar fracture, and the diagnosis is confirmed through X-ray. Now the management options. So first of all, type 1 fractures are undisplaced. In type 2, angulated posterior but posterior remains intact. In type 3, fractures are completely displaced with overlapping of the fragments. So the treatment is that it should be treated conservatively, and the fractures are treated by close reduction and cast fixation with elbow at 90 degree. Okay, as we have studied that there is a procedure known as hanging cast, in which the plaster of Paris is used, which is extended from the axilla to the wrist. So in this case, the casting method is used for the fixation. That is, fractures are treated by close reduction and cast fixation with elbow at 90 degree. Now the treatment is that reduce under anesthesia by traction and manipulation, but open reduction may be needed if closed reduction failed, or if there is vascular injury. Reduction is maintained by K-wires. Okay, so this was type 1 fractures are undisplaced, type 2 fractures angulated posterior but posterior remains intact, and type 3 fractures are completely displaced with overlapping of fragments. This is the treatment option that if it is type 1 fracture, that is fractures are undisplaced, then it should be treated conservatively. If it is type 2 fracture, that is angulated posterior but posterior remains intact, and it is fractures are treated by close reduction and cast fixation with elbow at 90 degree. If it is type 3 fracture, that is fractures are completely displaced with overlapping of fragments, then reduced under the anesthesia by traction and manipulation, but open reduction may be needed if closed reduction failed, or if there is vascular injury, and reduction is maintained by K-wires. Okay. The most common fracture around elbow in children, and it is usually result from fall on outstretched hands. It is supracondylar extension and flexion. Extension types are type 1, which is the fractures are undisplaced. Type 2 fractures angulated posteriorly but posterior brainstem remains intact, and in type 3 fractures are completely displaced with overlapping of fragments. Okay, so this is majorly a case of the supracondylar fracture, and the management options of ischemia in these patients is that immediate exploration should be done, the reconstruction of the brachial artery through autologous venous grafting or primary resection and anastomosis, and post-operatively anticoagulants, for example heparin, are given. The complications are vascular injury, brachial artery, nerves, radial, ulnar and medial, and malunion or non-union. Okay, let's revise this case. There is a boy who fall on outstretched hands. Remember, whenever there is a clue of fall on outstretched hands, outstretched hands. So it is supracondylar fractures. Supracondylar. Okay, so there is fall on outstretched hands, unable to move his right elbow, painful and swollen and abnormal in appearance, pain on slightest movement, and right forearm and hand is cold as compared to left. So the management option is done according to the type of fracture. This is type 1, type 2 and type 3 fractures. We are having these types. The type 1 fractures are undisplaced fractures. The type 2 fractures are angulated posterior but posterior remains intact, and the type 3 fractures are completely displaced. In type 1 fractures, it is undisplaced. In type 2, it is angulated but it remains intact, and in the type 3 it is completely displaced or separated with overlapping of fragments. So the treatment for type 1 is conservative treatment. For type 2, the fractures are treated by closed reduction and cast fixation, and in the type 3, reduced under anesthesia by traction and manipulation, but open reduction may be needed if closed reduction failed or if there is vascular injury. If the closed reduction can't be done, then surgery is done, that is open reduction, and the reduction is maintained by K wires. K wires are used to do the closed reduction, the open reduction. Okay. The most common fractures in the elbow are these types of fracture, that is supracondylar, and these are the types. Type 1 fractures are undisplaced, type 2 fractures angulated, and type 3 fractures are completely displaced. Okay, so this is the management option of ischemia, that is immediate exploration. Reconstruction of the brachial artery is done through autologous venous grafting. How? Through venous grafting. We should give the heading of venous grafting, that the management of the ischemia in the patient is done by venous grafting, and the reconstruction of brachial artery through autologous is done. Or primary resection and anastomosis is done. This is the first method, then this is the second method, that is primary resection and anastomosis, and post-operatively anticoagulants or heparins are done. So this is the third option. How we will manage the ischemia? First of all, the venous grafting is done, then the anastomosis and primary resection is done, and the third thing is that anticoagulants are given. Venous grafting, primary resection, anastomosis and anticoagulants. Venous grafting, primary resection and anastomosis and anticoagulants. These are the options for the supracondylar fracture of the humerus. These are the complications, that is vascular injury or brachial artery injury, and nerves damage, that is radial, ulnar and medial, as these nerves are present at that area, and malunion or non-union. Okay, so for orthopedics, remember that wherever the fracture occurs, so there may be malunion or non-union, and also there is the damage to the vessels, that is vascular injury, the arteries that pass there, for example brachial artery, and also the nerve damage, that is radial nerve damage or ulnar nerve damage or medial nerve damage. So this was about the supracondylar fracture of humerus in children. Now coming towards the next topic, that is the fracture of the neck of femur. Hello everyone and welcome back. So we are going to discuss the topic fractures of neck of femur. So we are having a scenario that there is a 60-year-old female under treatment of carcinoma breast developed sudden severe pain in right hip, who fell down walking at home, and X-ray pelvis shows multiple lytic lesions in upper femur with fracture of neck of femur. So what is this fracture called, and what are the pathological intracapsular fractures? What are the primary tumors commonly spread by bloodstream to the bone, and what is the management? Another scenario is that there is a 72-year-old woman who fell at home, severe pain in the right groin, has been unable to get up since fall. On examination, right leg shorter than the left and is externally rotated. Unable to actively lift her leg, and distal pulses and sensations are normal. So what is the diagnosis? What are the classification of these injuries, and what is the management? Okay. So in this scenario, it is mentioned that there is a aged female. The fracture of femur is common in aged people. Okay, you should remember these points. And she is under the treatment of carcinoma. Now in carcinoma, there is increased risk for the fractures of the femur, that is large bones. So she is having the carcinoma of breast, and she develops sudden severe pain in right hip and fell down walking at home. X-ray pelvis shows multiple lytic lesions in upper femur with fracture of neck of femur. Okay, so she fell down walking at home. X-ray pelvis showed multiple lytic lesions. X-ray was done and it shows multiple lytic lesions in upper femur with fracture of neck of femur. Okay, so what is this fracture called? This is pathological intracapsular fracture. Whenever the fracture occurs due to any other pathology, for example, carcinoma of breast is present, so this is the pathological intracapsular fracture. Now, what are the other primary tumors commonly spread by blood streams to the bone? So, the other primary tumors which leads to the spread to the bone is breast tumor, lungs tumor, and prostate cancers. Okay, these are the most common: the breast, the prostate, and the lungs cancer. And what is the management option for this fracture? In another scenario is that there is a 72-year-old woman who fall at home, fall history, severe pain in the right groin. Remember, whenever there is the fracture history, so there should be a history of very severe pain. She has been unable to get up since fall. On examination, right leg is shorter than the left and is externally rotated. She is unable to actively lift her leg and distal pulses and sensations are normal. So what is the diagnosis and what is the classifications of these injuries and what is the management? So this is the intracapsular fracture of the neck of femur. Okay, it is fall history and severe pain, and the one leg is shorter than another. So this is the intracapsular fracture. What is the classification of these injuries? We would do the classification and the management. So the classification of these injuries, we are having the Gardner classification. So in the Gardner classification, we are having the grades, that is the grade 1, the grade 2, the grade 3, and the grade 4. The fracture injuries classified is as grade 1, grade 2, grade 3, and grade 4. Okay, 4 types of grades are present. In grade 1, the fracture is an incomplete fracture of the neck. Medial trabecular intact and vascularity is reserved. In grade 2, there is complete fracture of the neck without displacement and trabecular aligned and vascularity is present. Grade 3 is moderate displacement of less than half the diameter of femoral neck and trabecular and vascularity is disturbed. In grade 4, the complete off-ended femoral head, fully disrupted trabeculi and vessels are present. Okay. So this is the classification of the injuries: grade 1, grade 2, grade 3, and grade 4. In grade 1, we are having the incomplete fracture of the neck of femur, that is medial trabecular intact and vascularity is resolved. Vascularity is not disturbed and medial trabecular is intact. In grade 2, we are having complete fracture of the neck without displacement and trabecular is aligned and vascularity is preserved. Okay, in grade 2, the complete fracture of neck without the displacement and trabecular aligned and vascularity is preserved. In grade 3, there is moderate displacement of less than half the diameter of femoral neck. In the grade 4, there is complete off-ended femoral head, that is fully disrupted trabeculi and vessels. So there are 4 grades. In grade 1, incomplete fracture. In grade 2, complete fracture of the neck without the displacement. In grade 3, complete fracture with moderate displacement of less than half the diameter of femoral neck. In grade 4, complete off-ended femoral head. Okay, incomplete, complete, then the complete fracture with the minimal displacement, and then the complete fracture with total displacement. These are the 4 grades of the fracture dislocation, that is Gardner classification of these injuries. Now the management options. So the management is intracapsular, in which we are having the undisplaced and displaced. Okay, as we have discussed the grades of these injuries, that is grade 1, grade 2, grade 3, and grade 4. So the management is provided according to the grade. If it is undisplaced fracture, then it is treated by internal fixation with dynamic hip screw. Treated by internal fixation with dynamic hip screw. If it is displaced type in elderly osteoporotic patient, is treated by replacement of the compromised femoral head by artificial head. What has happened that the compromised head is replaced by the femoral head. In young patient, urgent reduction and internal fixation by using uh, Okay, in young patient, urgent reduction in internal fixation is done, and in elderly patient, osteoporotic patient is treated by replacement of the compromised femoral head by artificial head, that is hemiarthroplasty. Okay. In extracapsular, all cases require surgical fixation of the fracture by using sliding hip screw and plate. Okay, so you should remember this point that in the femur, all the fractures, whether it is grade 1, 2, 3, or 4, it requires surgical fixation of fracture by using sliding hip screw and plate. If it is undisplaced, it is treated by internal fixation with dynamic hip screw. Undisplaced and hip screw is used. If it is displaced and in elderly osteoporotic patient, okay, if it is displaced, then we are having the conditions. One is the elder patient and one is the younger patient. If the patient is elder patient, then the head of the femur is replaced. If the patient is the young patient, then reduction in internal fixation is done. Okay, so this was all about the fracture of the neck of femur. So this is the intracapsular pathological fracture of the femur, and it is due to the underlying any other pathological cause, that is aging or falling history or cancers. And what are the tumors that can lead to the spread of the bone? So these are breast tumors and prostate tumors and lungs tumors, okay, or lung cancers. Then we are having the management options and the grades, the classification of the injury. So we are having grade 1, 2, 3, and 4. In grade 1, there is incomplete fracture. In grade 2, there is complete fracture but no displacement. In grade 3, we have complete fracture with minimal displacement. And in grade 4, we are having the complete off-ended femoral head, complete displacement, as well as the complete fracture. Then we will provide the management options. So management option is provided according to the grade, and it should be remembered that the surgical requirement is done in all cases of the fractures of femur. If it is undisplaced, then it is treated by internal fixation with dynamic hip screws. If it is displaced, then in elderly patient, the head of the femur is replaced. And if it is done if it is the case in the young patients, then reduction in internal fixation is done. And in extracapsular, all cases require surgical fixation of the fracture by using sliding hip screw and plate. Now coming towards the next case, that is femoral shaft fracture. So we are having a scenario that there is a 30 years old and he is having a fracture of the right femoral shaft. That is, we are having the fracture of femur, but now this time there is a fracture in the shaft. In the previous section, we have discussed a fracture of the neck of the femur, and it is usually due to the increased age or the carcinoma, and it is called the pathological intracapsular fracture. Now in this scenario, it is pretty obvious that this is the fracture of the femoral shaft. So what is the treatment, the complications, and the classification of the fractures? So we will discuss this. Management in adults and management in children is different. In the adults, first of all, traction is done. That is, for fractured mid-shaft femur can also be used in adult, but requires the patient to stay in bed for 12 to 16 weeks. Okay, first of all, the traction is done. Then external fixators are applied, that is applied to the lateral side of the femur to stabilize the fracture. Then internal fixation is done, that is performed with plating or intramedullary nail. Nails or plates are used. Intramedullary nailing and replacement of the blood loss is also done. Okay, this is the basic method. What is done? First of all, if there is the fracture of the femur shaft, then traction is done. That is, for fractured mid-shaft femur can also be used in adult, but requires the patient to stay in bed for 12 to 16 weeks. Then external fixators are applied to the lateral side of the femur to stabilize the fracture. Then for internal fixation, perform with plating or intramedullary nail. Intramedullary nailing and replacement of the blood loss is done. Now the treatment of the associated injuries. In children, it is treated with traction, that is traction for infants and balance traction for children. Okay, in children, it is treated with traction, and it is gallows traction for infants and balance traction for children. Gallows traction and balance traction. Okay, so these are the method for the treatment of femoral shaft in children. The complications of these fractures are vascular injury, nerve injury, non-union, malunion, knee stiffness, and refractures. Okay. Classification of the fracture we have discussed it already, and the complications are vascular injuries, nerve injuries, non-union, malunion, knee stiffness, and refractures. These are the complications. So this was a small topic, that is the femoral shaft fracture, and we have the management options different in adults and in children. In adults we will do the traction, then we will do the apply the internal fixators and external fixators, and then we will do the intramedular nailing, and also the replacement of blood loss is done. The treatment of the associated injuries is done in children. It is treated with traction, and the complications are vascular injury, nerve injury, non-union, malunion, knee stiffness, and refracture. Now the next topic is tibial shaft fracture. So we are having a scenario that there is a 50-year-old having compound fracture of the shaft of tibia. So what is the management, the complications, and the treatment of complications, and the common sites for the tibial side fractures. So this is also the common question that is asked, that what is the common site for the tibial shaft fracture. So these are the proximal 2/3 and distal 1/3. These are the common sites, proximal 2/3 and distal 1/3. This is also known as bumper injuries. Okay, tibial shaft fractures are also known as bumper injuries. This is a kind of MCQs, you should remember this. Now the management options for the tibial shaft fractures. First of all, follow the ATLS guideline, then debride the wound, then analgesics are given, antibiotics are given, tetanus prophylaxis is done, and external fixation of the bone is done. Okay, this is the general management. This management you can also write this in all other types of fractures, that first of all ATLS guideline is followed, then the debridement of the wound is done, analgesics are given, antibiotics are given, tetanus prophylaxis is done, and external fixation of the bone is done. Then we are having the closed fracture and the open fractures. So the closed fractures, we are having non-operative methods. For example, long leg pop cast is used, and for the in case of failure of non-operative treatment, require fixation with plates or nail. And in the open fracture, tibia is most common site of the open fracture, as most of part of tibia is lying subcutaneously, and skin closure is difficult, and plastic surgical intervention is required to cover the exposed bone by flaps. Okay. If the tibial shaft fracture occurs, then we are having the closed fracture and the open fracture. So in the closed fracture, non-operative methods are used. For example, if it is a long leg pop cast is used, and for the failure of non-operative treatment, in case of non-operative treatment, then fixation with plates or nailing is done. And for the open fracture, skin closure is difficult, and plastical surgical intervention is required to cover the exposed bone by flaps. Now the complications of the tibial fractures are vascular injury and delayed union and non-union, malunion, and foot drop. These are the common complications that are present in all the types of fractures. These are vascular injuries, delayed union, non-union, malunion, and foot drop. Okay. Now the next topic is osteomyelitis. Okay, let's revise this. Tibial fracture, we have discussed the management options, and it is for both closed fracture and open fracture. And then we are having the complications. Okay. Now coming towards the next topic, that is osteomyelitis. Osteomyelitis, septic arthritis, and carpal tunnel syndrome, and compartment syndrome. These are the topics that are remaining, and these are also the very important topics, and the common topics that are asked the examination wise are these topics. So coming towards the next topic, that is osteomyelitis. So what is osteomyelitis? It is the bacterial infection of the bone. Whenever the bacteria cause infection in the bone, it is called osteomyelitis. We are having the acute osteomyelitis and chronic osteomyelitis. Acute osteomyelitis, it is a disease of the childhood and often follows respiratory infection and skin infection. It is a disease of the childhood and it often follows respiratory infection and skin infection. And the clinical features are pain. In osteomyelitis, there will be pain in the bones and pyrexia along with the femur, and there will be tenderness and systemic toxicity. That is, toxicity will be present all over the systems, and there will be pain and tenderness. Now the investigations for osteomyelitis are specific investigations are WBC count will be raised. There will be raised C-reactive protein, and there will be raised ESR, and the X-ray test is done. X-ray is done, which change is not visible for 10 to 14 days. Okay, if osteomyelitis occur, then the changes are not visible for 10 to 14 days. Then isotope bone scans are done, and CT scan is done, which shows the bone erosion and fluid collection, and MRI is the investigation of choice, which shows the edema of marrow and collection of pus, and blood culture is done, and microbiology is done. These are the specific investigations that are done for the case of osteomyelitis. Then the management options are resuscitation, and antibiotics are given after culture and sensitivity, and intravenous antibiotics for 2 weeks are given, which are followed by 4 to 6 weeks of oral antibiotics. And splintage of the affected limbs is done, and radiology guided respiration of the pus is done, and cortex of the involved bone may be drilled at 2 or 3 sites to decompress underlying pus, and the sent for culture and sensitivity for appropriate antibiotic therapy. The complications are recurrence and chronic osteomyelitis and septic arthritis, pathological fractures, damage to the growth and plate. Okay. Okay, so this is osteomyelitis, and we are having let's revise it. Okay, so sequestrum and involurum. Involurum is new bone form. So this is sequestrum. In it, microscopic dead bone occur, and in involurum, new bone form under area of osteomyelitis in response to periosteal stimulation. Okay, now osteomyelitis, we are having the bacterial infection of the bone, and it is acute and chronic. And in acute osteomyelitis, it is a disease of the childhood, often follows respiratory infection and skin infection. And the clinical features are pain, pyrexia, tenderness, and systemic toxicity. The investigations are WBC count, CRP, and ESR raised. X-ray change is not visible for 10 to 14 days. Isotope bone scans. CT scan shows bone erosion and fluid collection, and MRI shows MRI is investigation of choice, showing edema of marrow and collection of pus, and blood culture is done, and microbiology is done. Okay, as it is a bacterial infection, so first of all, in case of inflammation or infection, WBC count is checked, and in case of the inflammation or infection, ESR is raised and C-reactive protein is raised. So WBCs will shows that there is infection. X-ray is done, but the X-rays will show the results, that is changes after 10 to 14 days. And the bone scans, isotopes are done, and CT scans are done, which shows the bone erosion and fluid collection. CT scan is the true choice, and it shows bone erosion and fluid collection. MRI is the investigation of choice, and it shows the edema of marrow and collection of pus, and blood culture is done to find the causative organism, and so that the specific treatment is provided. And microbiology is also done for this causative organism. So what are the main investigations of choice? That is WBCs and C-reactive proteins and X-rays and bone isotopes and the culture and microbiology and MRI and CT scan. Now the management options for the osteomyelitis are that first of all, the resuscitation is done. Then antibiotics are given after culture and sensitivity. Intravenous antibiotics are given, which are 2 weeks followed by 4 to 6 weeks of oral antibiotics. And splintage of the affected limbs is provided. Radiology guided aspiration of the pus is done, and cortex of the involved bone may be drilled at 2 or 3 sites to decompress the underlying pus, and seed for culture and sensitivity for appropriate antibiotic therapy. Okay, so the management options are resuscitation. The antibiotics are given after culture and sensitivity, and intravenous antibiotics are given 2 weeks followed by 4 to 6 weeks of oral antibiotics. Then splintage of the affected limbs is done, and then radiology guided aspiration of the pus is done, and then cortex of involved bone may be drilled at 2 or 3 sites to decompress the underlying pus, and it is sent for the culture and sensitivity for appropriate antibiotic therapy. Okay, so the cortex of the involved bone may be drilled, and radiology guided aspiration of the pus, as it is a bacterial infection, so pus form. So for it, the cortex of involved bone is drilled, and pus is drained out, and it is sent for the culture, and the radiology guided aspiration of the pus is done, and splintage of the affected limbs is done, and the resuscitation is done, and antibiotics therapy is given. The complications of osteomyelitis are that recurrence may occur, and the pathological fractures occur. What are the pathological fractures? Any fractures that occur due to any underlying condition or disease. Then chronic osteomyelitis may occur, and damage to the growth plate can occur, and septic arthritis can occur. These are the complications. Okay, septic arthritis, recurrence, chronic osteomyelitis, damage to the growth plate, and pathological fractures. Now coming towards the next topic, that is septic arthritis.